Hey everybody, I'm Maggie and I am here with staff orthopedist Dr. David Podeszwa for another session of Facebook Live. Welcome.
Thank you. Thanks for
We're
having me.
happy to have you here. This is another week and we're talking about developmental dysplasia of the hip. Kind of a tongue twister there. So
Yes.
Why don't we get started? What is DDH?
So DDH is developmental dysplasia of the hip, and it's actually a spectrum of disorders of the hip that can occur at different ages. But when we talk about an infant, which is sort of what we'll kind of focus on today, sort of infant through the first year of life, let's say, we talk about a child whose hips can be normal at birth or abnormal at birth, and then it's a spectrum of whether the hip is loose and wants to come out of the socket, or some kids where the hip is actually all the way out of the socket. We use the term developmental. For many of our parents, always heard the term congenital dislocation of the hip, but we know that there are a lot of kids who are born with normal hips and then the hips may become abnormal as they develop in the first year of life.
Okay, so what should parents be looking for in terms of symptoms? Because a lot of this happens, are babies 7 days old coming to you?
Sure. Well, interestingly, the parents may not notice anything unusual, and this is usually picked up on the screening exam by the pediatrician frequently when they're first born. It could be at the first 2-week well-check visit where they pick something up, or it could be even at a later well-check visit that there's some abnormality with the motion of the hip,
okay,
or they feel that the hip feels loose when they examine it.
Okay, and then in terms of, is there a certain demographic who gets? Is it boys, girls?
It's definitely more common in girls.
Okay.
It's definitely more common in Caucasian girls. So Caucasians and Native Americans have a much higher incidence of this than African Americans do, or those of Asian descent.
Okay.
And usually when you talk about sort of what is the incidence of DDH, we usually roughly use the term about 1 out of 1,000 babies will have DDH. Now that number can be a little bit higher depending on how you're screening for it, whether it's just a physical exam or whether you use an ultrasound exam as well. So I should take one step back and say that one of the things that will commonly initiate a visit to see us is the baby, the pediatrician or mom or dad or someone will feel a click around the hip when they're wiggling the hips around or they're changing the diaper, and they may feel a click on the hip. Now that click can either be from the hip or from the knee, but the vast majority of times that click is completely benign, and it's just a muscle or tendon rubbing around the hip. But it's enough to generate some angst and concern, and we're happy to see that. And if that's the case, we still will screen as we normally would to make sure that the hip is normal. Okay,
so you were talking about how a pediatrician might be finding this by feeling around with the hips. So what happens when a parent brings their child to Scottish Rite? What will happen in the exam room, and what will our specialists do?
Sure, a little bit. So there's some things that we do routinely, and then some things depending upon age. So routinely, we're going to take a good history because we want to know a little bit about the birth history of the child, because that helps guide us a little bit on what are the risks of this child having developmental dysplasia. We know that there are risk factors involved. There's kind of 5 primary ones that we look at. So a firstborn child, particularly a firstborn female, is at a higher risk than others. If they're born breech, that's a very high risk factor. Having a family history, so if mom has had dysplasia or had hip problems as a child, or if any of the child's siblings had hip problems, that also increases the risk. And then there's other issues that we call what we call packaging issues. If the baby has torticollis, which means that there's a tightness in the range of motion of the neck, or they have metatarsus adductus, which is a condition where there'll be a deformity of the foot, or club foot is a different type of deformity, but these are also associated with increased risk. So we want to take a good history to help us sort that out. Then once we do that, we'll examine the child. And we looking for looseness in the hips. And is the hip loose, and can we push it out of the socket? Or is the hip out of the socket, and can we push it back in the socket?
Okay.
So these are all things that we'll do for everyone. Now what we do after that depends a little bit upon the exam and the age of the child. So if we examine the child and the exam to us feels completely normal, but the child is less than 6 weeks of age, we will most commonly ask the family to come back with the child after 6 weeks of age so we can do an ultrasound after 6 weeks of age. We've learned over time that the ultrasound is far more reliable after 6 weeks of age. With a normal exam, an ultrasound less than 6 weeks of age often gives us too much information and suggests that there's something wrong that needs to be treated, when very, very frequently that will resolve itself normally over the first 6 weeks.
Okay. So let's get into treatment for this. I know that this can come at various ages, but what are the different treatments, and does that determine the age of the child that you do a certain treatment on, and is there certain specific treatments for the age?
Sure. We'll start sort of young and work our way up, but usually for an infant, if we are concerned that the hip is loose, we can push it in and out of the socket, or we can frankly, or it's out and we can push it in and it's out and we need to help it get in. Almost routinely, we will start with, well, it is routinely, we will start with what's called a Pavlik harness.
Okay.
So a Pavlik harness is a fairly simple device made of Velcro straps that helps hold the hips up and out to allow the hip to be pushed into the socket. And of course, we have an example of one.
Yes, we brought it.
So this is an example, of course. This child's a little bit bigger than sort of a newborn or an infant that we would first put into a harness. But we certainly, the Pavlik harness is used anywhere from birth up to 6 months of age. 6 months is definitely the high end, because once a child gets bigger and mobile and kicking and wants to roll over, then it becomes very difficult to keep them in the Pavlik harness. But the Pavlik harness is a series of Velcro straps that helps hold the legs up and out. So I'm going to lay the baby back down. But the hips are held what we call flexed, so above sort of 90 degrees of hip flexion and abduction. And what that does is that points the femoral head, or the ball, into the socket. And the socket, the socket needs the ball needs that stimulation from the ball to develop, and the ball needs that socket to help it develop as well. So that relationship is really important.
Okay.
So for the vast majority of times, this is all a child will need.
How often are they coming back to be checked up on this? So if you put them in a harness, is it weekly, monthly?
A little bit depends on the condition of the hip. If the hip is in and it's just that the socket hasn't developed yet very normally, then frequently we'll see them back 1 week after we put the harness on to make sure that the child's comfortable in the harness and the harness is positioned appropriately and the child's doing well. And then we'll frequently wait 3, 4, 5 weeks after that to give it the hip a chance to develop before we recheck an ultrasound. If the hip is out and the harness is helping bring the ball in the socket, then we will obtain an ultrasound every week until we prove that that ball is in the socket. If after 3 or 4 weeks the ball is not in the socket, then we'll discontinue the use of the Pavlik and then have to talk about other potential treatment options.
And how long are they normally wearing this?
So minimum of 6 weeks, but it can be anywhere from 6 to 12 weeks. As long as the ball is in the socket and we're seeing progress, it'll be generally 6 to 12 weeks of use.
And is it 24 hours a day?
Again, a little bit depends on the condition of the hip, but most times it's 23 hours a day, so we take them out, allow the family to take the child out of the Pavlik harness for a short time for bathing, and then put the harness back on. But like other braces, it only works if you're wearing it, so we really try to encourage it to wear it all the time.
Yeah, so then what about some other treatments for this? Is there observation, or is surgery ever an option?
Yeah, we try to avoid surgery at all costs. We do observe some children when they're very young, sort of somewhere between 1 and 2 months of age, or less than 6 weeks of age. If we're concerned, sometimes we'll watch them. If the hip is stable, you mean normal on exam, and where ultrasound is a little abnormal, frequently we'll watch them for a short time. But if the hip is loose or out, obviously they're all going to get treated. If the Pavlik harness doesn't work, then there are times where we will have to consider putting them in a cast. So sort of put the hip in a position like the Pavlik harness, but it's a harness that it's a splint you can't take off.
It's there for a while.
Yes. And sometimes if that doesn't work, we have to then go to what's called an open reduction, meaning a surgery where we actually open the hip joint and put the ball back in the socket, because in certain cases, no matter how hard you try, that ball will not go back into the socket on its own, and that there are structures that are blocking that ball from going back into the socket, so we have to move those out of the way and get the ball back in the socket.
So then thinking about long term, obviously this depends on the baby and the circumstance of the hip, but what are some of the long term consequences that DDH could cause for a child if there's a bad
Sure.
case?
I will tell you that, more than 90% of the kids that have either an unstable hip, a loose hip, or dysplasia that we find on ultrasound, more than 90% of those kids are going to do well with the harness and won't necessarily need additional treatment. But there are kids that we have to watch for that can, one, seem like they're being normal when you treat them for the first 2 or 5 years of their life, but later on down the road the socket may not continue to grow normally, and not because of the treatment but just because of the underlying condition.
Right.
And so those kids may need to be followed long term and may need surgery in the future.
Okay.
Things that we always worry about with any sort of treatment is, particularly with the Pavlik harness, when they first initiate it, is making sure that they continue to kick their legs, because it can affect the femoral nerve, can sometimes make it go to sleep, being in that flex position, so we watch that right away. Other things that we worry about with other treatments, always worry about the blood flow to the head. Not so much with the Pavlik harness, but if we have other more involved treatments, then that can be problematic as we go along.
Definitely. Well, that's some really good information. I think we actually just got a question live, so we're going to get to that, which is pretty cool. So this parent wants to know, does a child grow out of this condition? Is there any long-term effect from DDH?
So if untreated, it doesn't necessarily get better. It won't get better on its own.
Okay.
If treated as an infant, and there's a very good chance that they won't need any treatment in the future. And again, the long-term consequences really are following the child over the long term to make sure that the hip continues to develop normally. We know there are a lot of kids that do really well as an infant and into their early childhood, but then as an adolescent or young adult, the hip may not finish developing quite normally, and that needs to be evaluated. And then what to do for that, a lot of that is based on symptoms.
Okay. And so we have time for one more question, and we're actually going to get one from Facebook. So another parent asked, is it possible for someone to have a bilateral hip dysplasia but only need a PAO or a total hip replacement on one hip?
Yes. So much of that depends on what the treatment was prior to this. So yes, bilateral hip dysplasia is very common. So to have both hips, a slow development or an abnormal development of both hips is very common. If they're treated as an infant, it is very possible that one hip responds and is completely normal, and the other hip may not respond as well and not grow normally. The question of a PAO, so for those who don't know, PAO is a periacetabular osteotomy. It's a fancy term for a surgery that we will do in patients who are skeletally mature. So once they get into their teen years or their young adult years, where we cut the socket free and rotate the socket to cover the ball more normally. So yes, that is a very real and very common scenario that happens.
Awesome. Well, thank you so much for joining us. That was
Thank you for having me.
a good session, and we're happy to have you here, and maybe we'll have you on in the coming months.
I'd be happy to.
So thank you again. Next week, tune in. We'll be talking more about pediatric hip conditions. Thank you.